NEMSIS 3.4 is what we're going to cover, and then some of the other features. But NEMSIS is the big one that kind of took the most time last time.
Yeah.
So I'll turn it over to Eric.
All right. Hey, thanks for coming in, guys. Is it too loud? I don't know if I can control the volume or not, but I'll try not to talk too loud to you guys.
Just leaving it, and then we'll...
Okay. So we did this last week. It went pretty good. We've been talking with John and Brian. You know, there's a lot of things dynamically happening with the IMS system, and we haven't necessarily been able to meet with everybody or all the agencies under Summa to kind of let them know what's out there, what's available now, and what's on the cusp of coming out. So that's kind of what the idea here is. Plus, two, wrapping up, showing you guys what the new NEMSIS 3.4 is going to look like. Any of you that are here that are gatekeepers are probably seeing that on the desktop. You know, what you're looking at now is a mobile version of the 3.4, not available for use yet. But as you'll see, the icons at the top and stuff look like the ones that are on your desktop. And what you basically see when we do make this transition, we create everything on that server side where your desktop clients are looking in, and then we replicate or clone that and basically send it out as a mobile with no records on it. So they're basically identical. So we have added some improvements to workflow along with the NEMSIS 3.4. What I'm going to attempt to do here is go through a call, point out some important factors in relation to the way that the call should be run, and most of you are probably aware of them already. And then I'm going to obviously hit on the things that are now a part of the NEMSIS 3.4. And like John said, if we can keep the questions toward the back end, I'll either have addressed them or we can kind of hit on them once I get through like the NEMSIS 3.4. So the one thing that we did is when you do start a run, if there's a run already been started on the tablet, we are going to present you with a dialog box that basically says, hey, you have a run. Do you want to create another run? Because I'm sure that you gatekeepers have seen runs coming up onto the server with basically no information. And that's either because somebody started a run, didn't realize they started a run, maybe somebody else grabbed the tablet and hit the start run button, or that they just double tap the start run. So you get those blank records come up, and then obviously you have to deal with them. So this would be an attempt to help suppress the amount of those that are occurring. So if you do have a second run that you need to initiate because you haven't got the first one off of there, you can just proceed and it'll comply. So the location button, the only thing that you guys won't see in here that I'm presenting is that wheelchair trip at the bottom, because we use that for private ambulance services, and I don't think any of you guys are doing those rehab centers to nursing home trips. But the three choices that you guys interact with, and this is fairly important for your crew members to understand, is transport, no patient. And I want to be real clear on how that's designed to be dealt with. The transport should be relatively obvious. If we go to the hospital, we have a transport. So where I see the confusion is between the no transport and no patient. No transport technically would apply to any call that you didn't go to the hospital, but that's not what that's supposed to be. That no transport is supposed to be, hey, we had an actual patient, we assessed vitals, we may have done some procedures, we may have even administered some medications, but no, we did not take them to the hospital. That is a no transport. Patient record necessary, vitals and all that good stuff populated, just like a transport, except we didn't go to the hospital. Anything else is a no patient. And I think the confusion comes down to, like, you go out and do a lift assist. We've always, for years now, called it a patient lift. Well, that's really not a patient lift. When we go out and help Grandma back into her chair, back into bed or whatever, if we're not doing vital assessments, procedures, medications, and all that kind of stuff, that's just a public service assist. You know, she's not injured. We're just doing a NIFRS basic report saying that our crew went out here to help Grandma get back into bed. So that is a no patient report. So is an open burn complaint. So is a CO investigation. So is an alarm drop, a fire call, a building fire, car fire, whatever it happens to be. Those are no patients. So I don't know how many gatekeepers here see that happen. You obviously can easily rectify that on the server side by changing it from a no transport to a no patient. Very simply. Steve, I'm sure you've done that. But if your crew members understand that logic, I think it will reduce the number of times that you're going to get those records come up marked inaccurately. The other thing you'll notice is if, for instance, I do select no patient. So for right now, if you look at my header row, you know I'm in the PCR. You can see the medications and vitals tabs. If I go to a no patient run, the couple things you'll notice is, for starters, if I suppress this, I'm in the NIFRS module now just by the simple fact of saying it was no patient. You'll also notice that I don't have a return mechanism back to my PCR. And that's by design. If you don't have a patient, I want to shut you out of the PCR. I don't want you putting patient demographic into a non-patient report. Now, if that happens, and you guys as gatekeepers are in the field or what have you, need to get to that PCR, well, think about the logic. If you switch that from a no patient to a transport, it's going to bounce you right back into the PCR. So I think that's important for people to understand, especially the crew members. And it's important for you to understand how to toggle between the two. So we've got a transport call initiated here. We'll just put in an arbitrary address right quick. Just so you guys know, depending on what agency you work for, that value that you see now is called a tracking value. Some agencies are using it. Some agencies, it's just hidden. But if you thought you had a reason to have some type of a tracking mechanism, some type of a value that would be beneficial for reporting purposes that doesn't apply to the state, then we can populate that. So, for instance, in East Wayne Fire District, they're a district that has merged a couple of fire departments. They go to Dalton City, they go to Marshallville, they go to Apple Creek. They want to be able to and are required to present to their board the number of trips that they went into those different segments. So that's a perfect place to put that, and your crew members walk right into it, and okay, I'm in Dalton right now, or I'm in Marshallville. If I don't know, then it becomes the gatekeeper's responsibility, to figure out where they happen to be. And then also your crew members would need to know, where they're actually at in order to populate that properly. But that is available to anybody if they so needed that. Really nothing significant has changed in regard to the times or the crew number or the run numbers or anything of that nature. This is all pretty straightforward. I hope everybody is aware by now that if you do tap into a time field, that it's bringing down the time above it. So if you went on scene at 12 o'clock and when you hit at patient time, it's going to bring that same time above it down. And that's to help you shorten the amount of clicks you have to make to get the time correct. So I'll just throw you can see that happen here. So if I put 20 here, when it jumps down, you'll see that it's set at the same time, 20. Will give us a little bit of time to get to the hospital and a little bit of time out at the hospital here. We'll just give it an arbitrary 999 run number. The one thing that you may or may not realize, if you do select a transport trip for mileage, loaded mileage, there is 2 fields right on the front interface to make it quick and easy for you. If your driver yells back what the mileage is, or you happen to get to the hospital and you look down at your odometer, we put it right there on the front interface for you. It does have to be a transport type call to see those fields, but you wouldn't need to interact with mileage if it was a no transport. So I'll just put in an arbitrary number here. We're going to pick a shift in a district. When you look at the crew members now, you'll notice right below the apparatus, I'm populating the action taken by that truck. That is a field that's now editable for you right there. This one here. I'm still defaulting it to an EMS transport if it's a transport type trip, but you can interact with that and change it. Nothing significant has changed with the incident type. So everybody understands the level of service, by the state's definition, that's the level of service that you provided the patient, not what you were capable of providing, but what you actually provided. So just because you have an ALS unit with 2 medics on it doesn't mean that you always have an ALS type level of service. If you just pick somebody up, put a Band-Aid on them, monitor, took them to the hospital, that would technically be a basic trip. So it's level of service provided, not what you're capable of. There are 1 or 2 other fields in here that you hadn't interacted with before, but these are just the type of transport mode, and some of these values have been modified a little bit for the new state protocol. I tried to keep the workflow as close to center as possible so that people really didn't have to relearn the solution. It's just going to be a few more fields that they're going to have to interact with in the solution. Nothing significant with mutual aid companies. So we're going to jump right into the patient tab. So that everybody is clear, we do auto cap for you, and we put on all the hyphens for the Social Security numbers and phone numbers and stuff to save you some time, if anybody wasn't aware of that. The ethnicity has been dropped from the state protocol, so you'll notice that that field is not available in the NEMSIS 3. If somebody currently screws up on a ethnicity, doesn't populate it or whatever, and you guys have to fix it, if you go under the patient's medication tab, I got that field in there, but I had to move it off of this primary layout because, as you can see, I really didn't have a lot of room for it. So if you have a record that doesn't validate because of ethnicity today, jump into the medications, allergies, and history of the patient, and you'll see that field in there. It'll be red, and you can fix it. Pretty infrequent because guys are going right through there, and they're used to picking those values. None of this has changed at all. This workflow ever so slightly changed here. When you come off of whether they were a resident or not, your next question would be, after you ask them about their doctor, would be, which hospital would you like to go to? So we'll just pick a hospital here. This one has changed a little bit. You'll notice that the hospital disposition type, the reason for you choosing the hospital are now in this shadowed popover. But you'll notice that there's two, and then you can't see the third fields to interact with up on the top left. So now, instead of a procedure of we activated the STEMI team, the stroke team, the trauma team, it's now part of the hospital disposition. So if I activate the STEMI team, I would indicate, yes, STEMI team. And then it wants to know what time you activated the STEMI team. So we'll just, and if you do notice right above that block, it's hard for you to see probably, but there are 2 times above there. The time that you arrived at the scene and the time that you arrived at the hospital, you should have activated the STEMI team somewhere in between those 2 times. If you happen to activate the team before you got to the scene, it's going to be red. And then the disposition of the hospital, this is a new state field. So if you took him to the OB floor, or you took him to the cath lab, or you took them to the ICU, which is probably pretty rare, you can actually indicate that to the, to the state. The only thing I thought was a bit peculiar is it doesn't just took them to the ED, just the default ER. It can be left blank, so you don't have to interact with that field. But I suppose if you took him to the OB floor and you indicate that you took him to the OB floor, you would be able to report on that in the future and indicate how many trips you made that you actually took him to another floor. Patient's history tab. The only thing that changed here is I removed everything besides history, medications, and allergies. So we'll just put a few history issues in here for Mickey. Give him a no known allergy. And then into the street address of the patient. And you can see that I have the little box to set the incident address. So if you're picking them up at their own house, you can just insert the address. The weight conversion from pounds to kilograms is actually under the resident tab now. It's actually on the front interface. You don't have to go behind to get to it, because there are people that like to interact with that. They like to populate the weight, then they get the kilo conversion. So I put it right on the front. If you happen to need to get back to the hospital disposition, you can see down at the very bottom right, I have a button down there that just says hospital details. And if I click on it, there I am. And if I want to get to my patient details, bottom left, same thing. There's my patient's history, medications, and allergies. So slight workflow change, but nothing that they shouldn't be able to easily find their way around. So some subtle changes to the patient tab. Signature. And while we're here, just so everybody knows, I deal with the billing agencies quite frequently. And the biggest request that I get from all billing agencies is that crew members get signatures when they can, and if they can't get the patient signature, to make sure that they get a crew member and an RN or physician assistant or whoever happens to be at the hospital receiving that patient signature at the bottom of this form. If you fail to get a patient signature or a hospital representative signature or the patient's caregiver signature, the billing agencies now have to seek that out. And what they usually do is they put a letter in the mail to the person who may or may not even be home from the hospital, and then they have to wait to get that back. So it can really significantly delay your billing processes taking place. So if your crew members don't get a patient signature, just insist that they get theirs and an RN, because they're always going to interact with an RN or a physician assistant or somebody at the hospital. Have them quickly sign. Your billing processes will be improved by that. The other thing that they actually ask me about on this form, too, that I do want to put a slight indicator on is when you can't get a patient signature and you sign and the RN signs, there is a reason box right here. Supposedly, the law requires or the regulations require that if the patient couldn't sign, there needs to be some definition on why they couldn't sign. So I suppose that could be whatever the reason that you happen to think is appropriate. They were unconscious, had a broken arm, whatever it is. I don't think it matters. They just need some kind of an indication on why couldn't you get the patient signature. So I'm going to probably make that highlighted if you collect the signature of the crew member and the nurse and kind of present that a little bit more, make it a little bit more obvious to the crew members to help direct them in the right location. So again, not a tremendous amount of significant changes to the patient tab, just a little workflow change. The disposition. One of the things that we did get back from the survey that we had done or John had put out last year was some of the value lists were too short, and I agreed with that from the beginning. Those value lists were established by the state of Ohio. The primary concerns were primary symptoms, primary impression, and I don't disagree with any of that. They were too short. But now you're going to see that list for symptoms has grown significantly. So you've got lots and lots and lots of options to choose from now. Just so you guys understand, the state, for the most part, has now adopted a national standard, the same way that the state adopted a national fire standard. Our NIFRS reporting, NIFRS is short for National Fire Incident Reporting System. NEMSIS is short for National EMS Incident Reporting. So because of that, we now have resources that have been worked on for probably 15 years across the entire nation. So we have a lot of values coming from committees, I'm sure, but it's probably better than having too few. So lots and lots and lots of options for symptoms. Same with impressions. They have improved or significantly increased the number of options that we can pick from. And the other thing, too, that I know a lot of people get concerned about is if I don't find an appropriate value in here for impression, symptom, or what have you, why can't I just type something? Well, the reason that is because when we talk to the state of Ohio, and NIFRS as well, we don't give them words. We use numbers for everything. So what they do is they let us know what the impressions are. So abdominal pain is going to have a number, and it might be whatever it happens to be, 16032. So that's the number that they get. It makes the computers able to communicate faster, and there is no error in the way you type the word. Or, you might call it abdominal pain. Somebody else might see ABD pain. Somebody else might call it belly pain. Well, those are all three the same thing, but unless you give it a number, you would have three different results. So that's why you can't just add whatever you happen to feel is the best case scenario. That also is the reason then that I added the chief complaint field, which does not go to the state of Ohio, which you can interact with and put whatever you want in there. So that is the difference between allowing you to have access to type versus a rigid, structured value list. So if you happen to get to the very bottom of the chief complaint field and you type anything in here, it'll be fine because we don't pass that information to the state. Anatomical location has not really changed. Even the values are the same. I am walking you into now the onset time. Before, I had it available, but I didn't walk you into it. If you don't have an appropriate onset time, you can leave it blank, or, in my opinion, I would say that when I presented to the patient, that's the onset. If they have no idea, if they're unresponsive, then the best I can put is, when I got involved, is the onset time. The workflow on the bottom here has changed a little bit. The injury tab is now hidden, so if I said we had an injury, you'll notice that I will be presented with all of the injury attributes. Those have expanded, but there isn't a tremendous amount of additional changes here. They have the same, what was the cause of the injury? Was it blunt, penetrating, this type of thing? And then they did add this trauma acuity. So if you put a tag on them, even if you didn't tag them, what did you interpret their acuity? Were they immediate, emergent? Were they deceased, or were they delayed? And then did you meet trauma triage criteria? I'm going to switch this back to no. The one thing you will notice is even if you have it as no, if you populate it in the fields, we're still going to allow you to get back in there and adjust those. One thing, too, that I think some people don't recognize, if you look at the trauma acuity up there, and I've already picked a value, now how do I get rid of that value? Well, if you click on it and you tap and hold slightly for just a second, you'll notice a cut, copy, paste at the top. If I cut it, it will take it out of there. So that's kind of a subtle mechanism that not necessarily everybody understands, that you do have cut, copy, paste in there. What you don't want to have happen, though, is your crew members copying, like a value from somewhere and populating it in another value box, because that wouldn't necessarily send the right number to the state, obviously. Okay? If you have a cardiac arrest, they have a whole bunch of fields that they want you to interact with. So I'll just go through those real quick here. Was it witnessed or not? Yes, it was witnessed. When was it witnessed? So if you have a time that they indicate when they witnessed them go down, you can fill that field. What was the cause of the arrest? What was the first monitored rhythm when you arrived to them and got a monitor on them? What was the rhythm then when you arrived at the hospital? Was there any prior aid provided before we arrived? Was there who provided that? Was there an AED there? And who applied the AED if there was? Did it help or hinder or not change the situation? Did they have a return to spontaneous circulation? Why did you discontinue your efforts? Well, if you had return to spontaneous circulation or medical control, told you that it was no longer necessary, or there were obvious signs of death, whatever the case might be. And then when did you discontinue? And then what was the end of arrest event reason? So there was return to spontaneous circulation. And then your resuscitative efforts, we can say that we assisted ventilations through a bag valve mask, and we maybe defibrillated, and then also did chest compressions via what mechanism? Manual, thumper. So considerably more fields to interact with on arrest. But nobody should really struggle with any of that, I don't believe. A lot of times there won't be an AED. A lot of times there won't be a witness. If you leave those blank, the subsequent fields will just not populate or present themselves. So it should be pretty straightforward. That's probably one of the biggest changes that the state made, is give me feedback on those arrests. I think they're interested in studying the effectiveness of CPR, which they've been doing for 50 years. They're interested in the AED out there in the shopping malls and all over the place, and the effectiveness of those. And then first responders, police officers carrying AEDs. So they want to try to get some good feedback from us on how that's working. We also have protective gear, it doesn't go to the state, but if you wanted to indicate that you wore an armored vest or, you felt it appropriate to wear a gown or a mask or something of that nature, that's all available here. These are not going to the state. But some people or some agencies like to say, how many times did we wear a vest out on a call? You'll notice two fields directly below the IMS logo. And I don't know exactly why they want this, but the state is asking for the initial patient acuity and then the final patient acuity when you arrive at the hospital. And it's basically like a trauma triage tag. So were they critical? Were they black, deceased? Were they emergent? Or were they green? We're going to default those for now to yellow because if they called you, they must have had something going on, at least in their mind they were emergent probably. But you can interact with those fields and change them to the appropriate. It's almost as if they're treating every call as a mass casualty type tag system. So. The vitals, similar workflow. The biggest change that you'll see in the vitals section is some of the values from procedures have now become values of vitals. And I've had multiple conversations with multiple different medics on that. You can look at that two different ways. I personally liked having the result of a procedure. Like if you did SpO2, you did a procedure SpO2, what was the result of the SpO2? Blood sugar, what was the result? But the state has adopted, or the national standard has adopted the fact that SpO2, blood glucose, cardiac rhythms, and capnography are all part of a vital assessment. And they have indicated that if you have the result of a procedure in a vital, you don't have to indicate that you did the procedure. We did leave those procedures as options to choose from. So if you do a 12-lead EKG, you're still going to have the ability to pick 12-lead EKG from a procedure, but it won't have the result in the procedure. Blood glucose, capnography, all the same thing. So that's just what they adopted. So if you'll notice down at the very bottom right, where I used to have the stroke scale, now is what is the cardiac rhythm? What type? So it was either 4-lead, 12-lead. I had that in there before as options to choose from. And then how did you interpret that rhythm? Was it the monitor that interpreted it? Did you manually interpret it? So pretty straightforward, just slight change of workflow. If you notice directly above the logo, that's then where you'll have your stroke scale. So I had to bury something on this layout, and I figured that stroke scale was less likely to be interacted with than any of the other fields. So that is now behind that button. And you also notice to the bottom left of that pop over, I have a button to set all those variables to normal. So even if you wanted to, give them a quick stroke analysis and everything seemed fine, you can set those all to normal. The one thing that they did add was what was the score? So was it a positive, was it a negative, or did you not understand, or were you not able to interpret the score? And that is a default Cincinnati stroke scale. So that's what we've been using since the beginning, is the Cincinnati stroke, grips, drift, speech, that kind of thing. The one thing, too, that everyone should take advantage of is the replicate function at the top of the vitals tab. So under normal circumstances, if it's a standard run-of-the-mill transport, the baseline vitals probably change each time you assess, but in a lot of situations, your AVPU and your Glasgow coma and your skin temperature and all those things are probably going to remain constant. If you do replicate and then you edit your baseline, it'll save you from interacting with those other fields. It's not required. You can literally go through and deal with each and every field individually on each and every vital tab if you so choose. So SpO2 is right here. End-tidal CO2 is here. pain scale, and then the blood glucose level, and then again the stroke. If you do replicate and you had presented yourself with stroke values, they'll replicate as well. Procedurally, again, we left the 12 lead. The 12 lead transmitted a 4 lead, blood glucose, all of that kind of stuff. If we say we did a 12 lead EKG, we're going to be dropped to the field of who did it, and then we're going to be taken into the details at 12 lead. Well, that's pretty straightforward. It either improved, unchanged, or worsened the patient's situation. If there was a complication to that procedure, you can indicate it. And then this is something that they allow for in vitals, procedures, and medications. Now, was it done prior to EMS arrival? So if somebody had put like a 12-lead EKG on before you got there, maybe at a stat care or a residence that maybe has, a doctor that resides there, or like a nursing home, so you go out there and they say, hey, we did a 12-lead EKG and it's showing us a STEMI. Well, you could indicate that there was a 12-lead done, it was done by a healthcare provider, and that it was a STEMI. And it was done prior to our EMS arrival. If you do an IV, it's going to be fairly similar to the way it was before. The size, the location. Probably the biggest change from the state on procedures is if we so chose to do a advanced airway. Now we're going to see there's additional fields here to interact with. So I'm going to put the size of the EK or the ET, and then it's going to ask you on advanced airways, what was the reason? Well, there was an illness involving the airway, or there was reflex compromise, or whatever you happen to choose here. What airway did you confirm? Well, I confirmed an ET tube. How did you confirm it? Well, I used waveform capnography. And then when did you confirm it? So I need to do it before I get to the hospital. And if you happen to have a complication to that advanced airway, you can see that there's still a box there that's yellow. It doesn't have to be populated, but if you failed the intubation or what have you, that's available. Failed intubation effort. What time? That time is the confirmation time. That'll apply for endotracheal intubation, King Airs, and combi tubes. I don't think we have any other advanced airways now, right? Oh, so let me step back. One thing I forgot to mention to you guys on the vital tab that is new is if you're unable to auscultate and you have to palpate a blood pressure, if you look right above the blood pressure, it says blood pressure auscultated. If I put that I palpated that, you'll notice that it switches to palpated and it puts a P in the diastolic. Up until now, and in fact currently, the way we're reporting, you can't use alpha characters to the state. The new NEMSIS standard allows for that P to be passed as a palpation. So just by simply changing that BP palpated, I'll put that P in there for you. And that was actually a request that came during the survey. But again, it was like we couldn't send a alpha character to a text or to a numeric field. They wouldn't accept it. Not allowed. Medications. Similar workflow. We're going to pick a med. I'm going to drop you into the dose, the unit, and the route. There are additional route features that we had not had access to before. Who did it? And then the same concept here. Did it improve, worsen, or unchanged? Let's just say it improved. These fields, so that you guys understand, are not, these other yellow ones, are not required by the state. But we did get feedback from agencies and medical control directors wanting to ensure that the guys that are administering medications in the field are considering the 7 rights. Right patient, right route, right unit, right time, all of those things. Now, if you are confident that you put them on O2 and it was the right patient, the right route, the right dose, it's not expired and all that stuff, there is a button to populate those values for you. So I'm just going to set them all to OK. The only thing that doesn't set is, was it also confirmed by another crew member? Because how am I supposed to indicate? Now, you can leave it blank, but if you happen to maybe push a narcotic and you did want to say that John was there to witness that administration of that narcotic, or you have your own protocols for that, you can pick that crew member that assisted or witnessed that. So they are yellow. They are not state required, but that should help from a protocol standpoint to kind of ensure at least your crew members are thinking about those things when they're administering medications. We'll talk a little bit more after we get done with the NEMSIS 3 on some of the things that are changing with the pharmacy board requirements for administering patient drugs. So this will actually help with that too, because, you know, did I have the right patient, the right route, the right unit, the right dose, the right da-da-da-da-da, was it expired? And then I have to also confirm that, yes, I am the one who administered that medication. The pharmacy board is getting a little more constraint on making sure that we are doing what we're supposed to be doing and that there is some oversight. Pretty straightforward, very simple workflow. Literally just go with it. It'll take you right to where you need to go with very little, you know, don't fight it, basically. Tell your crew members if they're new to it, don't fight it. You know, allow for the system, you know, try to work within the protocol, the workflow that's designed, that it's been designed for. And then the narrative. I did remove, I am automatically walking you through these fields. For some reason I see people not interacting with these fields. I'm not really sure why. And I'm not saying all people don't interact with them, but I see a lot of those coming up null for some reason. So I'm walking you into those. How did you find them? You know, did the hospital advise you any further orders? And, you know, did you transferred care to who? You know, an RN, a PA, whatever you want to put there. Signature of the crew member. So you'll notice down at the bottom, I got rid of that auto-calculated window. It's not that it's completely gone, because you'll be able to click on the auto-gen button and actually read your auto-generated narrative if you so choose to. But I needed a little bit more room down here. So I put those fields on the bottom left there that we already interacted with on the hospital, in case you forgot, you know, did we activate the stroke team, the STEMI team, the trauma team? And then what time did we activate that team? So it'll be presented to you both in the hospital tab and at the end of your report if you happen to forget about it. The timestamp button, I just relocated it slightly. It's just moved down a little bit, and I do take you in there to show you your timestamp. Is Worcester, well, anybody go to Worcester Hospital? You guys are probably a little closer to this side. The one thing that we're working with, but we're going to start working with Summa on, we've already put to place with the Worcester crew, is this wristband button. And what they're doing now is registration will give them a wristband, you know, basically as soon as they get the patient registered. And then the crew members, and I can show you how this works. It won't validate. I don't have a valid band. But if I hit that wristband button and I bring a card in, it'll scan it. Now, that's telling you that it's no good because it has to start with a series sequence of numbers and letters. So this card's no good for a patient ID. But by doing that, what then happens is that record, that patient care report, automatically gets populated with the hospital record. So there is no need for them to print and manually handle the paper and get it to the patient record and all that stuff. And it's been working very well for them. John's working with one of the outlying hospitals now to start that same process here, and then hopefully within a reasonable period of time we can all maybe consider that as a migration for the Summa group. It's working very well. I mean, we're trying very, very hard to get away from generating paper. We have been for quite some time. It has been a struggle, but I think we're making progress toward that end result. This would be one more avenue toward, one, it simplifies the hospital's processes because now they don't have to pay somebody or waste somebody's time trying to get all of those reports that you guys are creating associated with medical patient records and then, sent to wherever. It just becomes part of their automated process, and by that band being scanned, it's similar to your Social Security number. It's not, but it's a number that is unique only to you in the hospital. So when that comes up, it says, show me that patient's care record in the medical system. Okay, here it is. Okay, attach that report to it. And it's working very well for them. So as you can see, not a tremendous amount of workflow change. We have more fields. We have more fields to interact with. We have more options to populate those fields. We do allow you to control the auto-generated. So if you don't like the auto-generated narrative, if we look at this report, so of any of you that don't know, if we look at the report right now, you saw me type patient narrative or test narrative, but because of all the fields that we populated, we have a reasonable start to our narration of our report. And so that everybody understands, the way this is designed to work is the things that I consider to be a minimum for patient care reporting are what it is that you found, what it is that you did, and then what the outcome of what your procedures in that were. Well, you've already pretty much told me what you found, and you've pretty much told me what you did, procedurally, medication-wise. So I kind of outline that. I can't obviously auto-populate what the response from the patient was. So if you think about that, and you just you narrate the things that are not automatically populated here and how they responded, you should be able to save yourself a reasonable amount of time in your narration. If you don't like it, and I know there's people that don't like it, and I understand that, there is the button at the top right that allows you to just turn the auto-generated off. And then it'll just be the text string that you actually physically typed. If your agency says, hey, nobody uses that auto-gen, we always toggle it off. Well, we can set it as one of your variables that when you guys sign on, your auto-gen's off. And if somebody wanted to use it, they'd physically have to turn it on. I have it defaulted to on. I believe that if you use it and use it properly, it's going to help you be more efficient in your documentation. If you don't like it and you just insist on typing away, that's fine as well. There's no requirement to use it. But I think if you spend some time with it, and I've worked with people that told me they didn't like it, in fact, mostly on my station. Well, once I kind of talked them through it, like I'm telling you what you found and what you did, or you're picking those values. Shorten up your narration by what it is that the outcome was or any parameters that aren't filled in, and don't say the same thing on every single call and waste a bunch of your valuable time, especially while you're at the receiving facility. So workflow-wise, you can see it's pretty straightforward. Kept it as consistent across the board as what we possibly could to not require you to have to spend a lot of time training. You guys should be able to take most of this back at some point when we do release, and we just got our credentials to the state of Ohio. So we are now able to test to the state site. We were supposed to get those May 1. Originally, actually, the deadline was April 1. We were going to get them, and then they pushed back a month, and then we just got them. So they're a little delayed, but they are indicating to us that they are on track. So once we have tested our reports to the state and we're confident that they're okay, then we'll be pushing this out to the agencies. And the other thing that I like about this new solution, during the last 6 months, we've also wrapped this all up into one application that will be available for download from the App Store. So what that basically means, and for the update, we'll have you guys do it, but if you called me up and said, I'm XYZ Fire Department, and I heard you guys are, doing this, and I want to join up with you guys, I'll be able to send them a link that sends them right to the App Store, one download, and then the whole process will take place. So our enrollment and update processes will become easier, more simplified, and more efficient than what they were in the past because of that. One thing I want to mention on synchronization, since I have you guys here, and I said this to the last crew that we met with, the synchronization component is a complex component of our protocol. There are times, especially lately when we've been interacting with the state protocol changes, that we have to either take our sync server offline or have to do something to our sync server to dial it in. When that happens, you guys can't sync, and you've probably all had a period of time that a sync just didn't go. I will tell you that if that is the case, the best case scenario, or the best practice is walk away for a little while, because what we see, and we get every error come to us, what we see is when you have a failure, now keep in mind we have a lot of agencies, and they don't get a record up, what do you think they do? Well, let's do it again, let's do it again, let's do it again. Well, multiply that by all the agencies, and they're just pounding on us, and we're trying to do something in the back end. So the best practice for all your crew members, if you have a problem where you can't sync, walk away. First and foremost, unless it's a Wi-Fi issue, you're connected to your printer instead of the Wi-Fi, or your LTE is not on, don't try to fix it. You are not going to outsmart the program and be able to fix it, especially if you have no idea what you're doing. In fact, you may very well potentially cause yourself issues. Walk away an hour or two. Doesn't make any difference. The worst thing that happens here, and we obviously try to minimize this, is that the hospital may be delayed on getting their copy. But most of the time, those ED physicians are not going over to that stack of reports and trying to figure out what it is that you did to the patient before they start their procedures. They've already interacted with you or the nurse. They already have gotten the oral report. If there's a delay getting the hospital report, they'll get it. It just, that's our worst case scenario. So there are times when the sync server is offline. Unfortunately, in our business, there is no, hey, let's do it on Saturday morning when the office is closed. As you know, the office is never closed. So for us, it's, and the other thing, too, that we're actually looking at doing, in fact, we already put ourselves on Twitter. The thing I like about Twitter is, and I think it would be a good protocol, if I have a situation, hey, sync server is going to be offline for an hour, I could post a quick tweet on that, and anybody that wanted to follow IMS on Twitter, maybe you don't have that notification come right to your phone, but if you say, hey, check Twitter and see if IMS has got anything going on, and if I got a post that says, hey, we're offline till noon, I don't have 50 people text messaging me, emailing me, and then me having to respond to each of them individually. We can just kind of, and to me that seems like a positive way of kind of communicating with everybody, because there's so many of you, Okay, so that is NEMSIS 3.4 in a nutshell. Questions on NEMSIS 3.4? See, I got it all.
Eric, I have a question about, if you click on location.
Okay. Okay. Patient? Okay.
Why doesn't it change the primary role?
Okay, that's a good question. How should I process a patient refusal? Well, it's real simple. Go to the records, look at the top left button, and it says refusal. Just so you understand, that refusal button changes about 20 fields to populate for the state. And I can tell you right now what it's going to do is it's going to take my mileage out, because maybe I put my odometer beginning in, because I always do on the way to the call. It's going to null that out. It's going to null out the hospital that I chose as Alliance. It's going to do exactly what you just said and change the role, because I'm not doing that on the type of trip, but I am allowing you to set those fields with the refusal. So let's do that. What's that?
We don't always get it.
And that's the way you should process a refusal. So this is actually a very good question, and this is something that I do see maybe some not quite clear understanding of it. So I've got a call, and notice I do have a to and out of hospital time. You can see I've got some mileage. I chose Alliance Hospital. You just pointed out that it's still showing a transport, but they decided they don't want to go. We gave them some glucose. They woke up, hey, I don't want to go to the hospital. So I'm going to do exactly what you're asking here. I'm going to hit refusal. Notice a few things happened. you can see that the suffix on the run numbers now switched to an 01. And that should make it obvious to gatekeepers that that's a refuse type call. Also notice that my to and out of hospital times are null. Notice that my mileage is null. And I do that because a lot of crew members put their beginning odometer readings in while they're going to the call. So I'm going to wipe it out. And then the response, like you had mentioned, look at the transport mode and stuff. Also, so that you guys understand, look at the hospital. It went to NA. And then look at the hospital disposition. Reason is not applicable because we didn't transport. So you may not realize that all those things are happening unless you literally sift through here. But when you hit that refusal button, it's basically setting that call to be able to go to the state of Ohio's refusal protocol.
Why does that? Go back to the primary role still didn't change.
Well, the primary role was a transport. That was your primary role. I mean, you could have been a supervisor, or what are the other options? A non-transport, or what? But your primary role is a transport unit, or at least on an EMS call it would be.
Okay. So if it's a refusal, that can stay as a transport.
Yeah, I think what they're asking is what was the actual, not what you did necessarily.
You should have been SWAT.
Yeah.
Your primary role is unit training.
And quite honestly, I'm really not even sure why they need to collect that, because that's pretty obvious that our primary role was to transport.
Us and Norton go on the call, say we don't have any units, and one of our supervisors will go. All we're going to do is a NIFRS report. And
Yeah.
Because we're just going to bring the address, and when you guys, because you're bringing all the stuff. I think that's what.
Yeah, and quite honestly, with that, being said, and you know what, I was going to have John put it in the last newsletter, and maybe we will in the future. The state actually has a little bit of a breakdown that I think's very important for you to understand who's responsible for reporting. And they actually make it very simple. And here's the bottom line. Whoever took him to the hospital. It doesn't matter who the agency having jurisdiction is for EMS purposes. What he just said, he shows up, maybe he's a medic and he's got a full set of gear on his truck and he started doing some stuff. Well, he's going to basically be responsible for a basic incident report for NIFR saying, hey, Steve went here at this time with this truck and he did this, that, and the other, but it's not a patient side. You guys, Norton, took the patient in. You are the ones that are responsible for all of the documentation of the actual transport trip. So and I know that happens a lot. That happens with a lot of agencies. Maybe they're a volunteer agency and they get there and they don't even have enough crew members to transport, but they got a first responder on scene or a fire truck with an ALS set of gear on it. It happens. The people that take them to the hospital that finish that transport, even if you take an intercepted medic from their department, you are the agency having the transport role. You are the one responsible for the EMS record. And the state specifically says we do not want two records coming up on the same patient. So just because he went and started doing some stuff on the patient, they would not want for that patient record to come up twice, once from him and once from you.
Another question. Level of service on a refusal, what is the state?
I would just do BLS. I mean, obviously, though, if you started an IV and some other stuff, there would be an ALS level of service. But, I mean, if you just went and, gave him some oral glucose or something, it would just be a level of service that you provided to that patient, whether you took him to the hospital or not. But if you start an IV, you push blood glucose, that would be an advanced. And just so you guys know, I know the state collects that for whatever reason, but that's also being used by your billing agencies to try to figure out how they should apply the charge. And there is a difference between a BLS trip charge to Medicare, Medicaid, and insurance companies, an ALS-1 type trip, and an ALS-2. And an ALS-2, don't ask me for all the particulars, but if you do like innovation, defibrillation, and push 3 different drugs, that takes it to this next tier that they actually bill additional revenues. My opinion, the billing agencies should be looking for that, because I can tell you right now, all of our crew members aren't necessarily going to know what meets that ALS Type 2 standard. Good questions. The other thing, too, on a standard EMS call, when you only have one truck, it's pretty straightforward with the times, right? But if you have a bunch of different trucks, I can't necessarily auto-populate times other than allowing you to populate from your master times, because there's no way for me to control that. This is an example of that here. You'll notice that the details tab under the crew members and apparatus is red. Well, the reason that it is, and just so you know too, is I can look at my validation criteria, and it's probably, and in fact, I can read it immediately. It says that I'm not available for the next incident yet. That's because I don't have a returning time. I haven't either hit the returning button or populated a returning time. This is an important thing for your crew members to understand, especially if they don't know. If they don't know why the record is not validated, have them hit the validation criteria and cruise through it. Don't get focused too heavily on like the numbers. The numbers don't mean anything to us in the field. That's state numbers. But if you just cruise through it and read it, in generality, it'll probably tell you what's going on. And I can see here that, you know, I said that I activated a hospital team and I gave it a time and everything, and then I said it was a refusal, so it's griefing me on that. So if I do go returning, it's gonna go green for me. I still have a problem with the patient here. And it's probably in the details here. So here's where, you know, it's basically telling me you can't activate a STEMI team on a refusal. So I can null out my times here. And then I can maybe set this hospital team, to no. Get rid of our time. See if I clear this out. Any other questions, concerns with NIFRS? We're 1 hour in. That wasn't too bad for NIFRS, or NEMSIS 3. Not relatively speaking. You guys want to take 5? Taking my mic offline. All right, we can get back at it. It's about 20 after. If everybody's okay with the NEMSIS 3.4, we'll get away from that mundane stuff. I do want to show you some workflow changes on the NIFR side, some things that you'll actually probably like as opposed to things that we have to do. The one thing I didn't mention, and it should be relatively obvious, is in order for you to get to NIFRS from the EPCR, I used to have it in the header. It's actually below the IMS logo, so you'll see there's a NIFRS button there to jump over. I did have to move that. You guys like the icons at the top? A little syringe and whatnot? Added a little flair to it or what have you. Okay, so we're going to start a NIFRS run, and we'll say that it's a no patient. We'll just give it an address again here. No real significant change in, now the tracking's available here on the NIFRS side as well. Shift in district, put in a couple of times here. Obviously we have fewer times to interact with on the NIFRS side because we don't have the hospital stuff. We'll just put a truck. And let's do a, I want to show you guys a CO investigation. So I'm sure I have a CO call here in my list somewhere. This was actions taken, so we investigated. We'll change this truck over to an engine. And we'll put a couple crew members on here. I don't know sure if you guys are doing this now, but I am walking you to the unit from the crew member. I noticed some guys weren't changing that, so I'm physically taking you through that field now. Okay, here's where I would find my CO call. So I'll say carbon monoxide incident, and we did investigate it, and it was a single-family dwelling. We didn't have any mutual aid companies. So everybody's aware that, and you should be aware that a no patient report that you want to document who it is that you interacted with is the person involved. So they're not a patient, they're a person involved. And right now I've got however many, 8 that you could put on the report. The first one is the one that I'm going to use for some supplemental reports that I'm going to show you here. So if you get to this person's house and it is a CO investigation, and in this first one you put, we'll just say Donald Duck here. We'll bring in his address, and we'll give him a phone number. I stopped walking through Social Security. If you want to get a Social Security number for a person involved, you can, but I am no longer walking you through that. and we'll say that he was the occupant. And we can even have him sign. And in the narrative, we'll just say CO call for now. And the member making, I am walking you into. So this is something I added to the current NIFRs, is if you go to records and you look down below where it says that it's not been synced yet, you'll see there's a few boxes, and the last one to the bottom right says CO incident. So I'm going to select CO incident. I'm going to be taken to this place, and you're going to say, who was involved? Well, if I already put the person's involved information in, I'm presented with it. If I hadn't, then here you go. Go ahead and put it in. And you can see the signature and everything's there. So these are the questions that we would normally ask the residents on a CO type call. Have you had a headache? Any fatigue, dizziness, confusion, nausea, any flu-like symptoms? Is there more than one person with symptoms? Do you feel better when you're away from the residence or the structure? And did you evacuate? Then we'll go to our appliances. So you're walking around with your CO monitor, and you go to the gas furnace that is in the basement, and you find 55 parts per million. You go to the gas stove, which is in the kitchen, and you have, 75 parts per million. So on and so forth. Gas water heater, basement, 50. And like maybe the garage, which you could say is attached, and you had 0 parts per million, let's say. What type of an alarm system do they have? So usually they call us because they had a CO activation. So if you want, you can populate what type they had. And did they ventilate, or did they ventilate the premises? And were the appliances shut down? Did you leave a copy of the report that basically lets them know what concerns that they should have in regard to CO? Were there levels detected? Yes, we detected. And what was the highest level we detected? We're just going to say 75. This is the narrative that comes from NIFR. So if you want to continue to expand on your narrative, then go right ahead. We'll just say, with symptoms. We can have the crew member sign. We have Donald Duck's signature already. And we can put an email address in there. And by doing that, if we look at the report, very similar to fire prevention, we'll have the ability to email that recipient via the email that we put in there. We can obviously print it if we have a mechanism and leave a copy. And if none of those are available, you can pick up your copy between 8 and 4 at the offices Monday through Friday or what have you. So if you notice the report looks similar to a NIFRS report, it shows you the symptoms that they may or may not have presented with. It shows you the appliances that you interacted with and the levels that you found. It's got your personnel in your truck. And then the second page basically just summarizes, what concerns you would have with CO. So the narration that is below the level that we found, so you see where it says, was levels detected, and yes, how much? If I say that we found 5 parts per million, let's say, you'll see that the dialogue says, 10 parts per million or less have been detected. Well, if I change that value to, let's just say 100, whoops, I got to get out of there and go back in there. Let's say 150 parts per million. Notice the dialogue has changed to 100 parts per million or greater. And then it's a little bit more get out, stay out, contact a qualified representative to fix it's lethal, So there's 3 different categories. They're below 10, between 10 and 100, and above 100. And each one of those has a different narration. So that'll save you from having to have some other type of form to populate when you have those CO type calls. The other thing, too, that I thought I should have walked through, let's check. Oh, I'm sorry, that's in the other one here. So that's a CO call, real quick and easy. Let's just do the same type of call, but let's do an open burn now, because we all have to deal with open burns. Seems like spring and fall, for whatever reason. People are burning their yard waste and everything else. So same concept. We'll do an open burn, and you'll see the same similar format, very easy. person, Donald Duck, he's already been populated. If not, go ahead and populate him. What was the size of the pile? So it was 3 foot by 3 foot by 3 foot high. Does that conform to your jurisdiction's pile size, and height? Yes or no? Well, yes, it was fine. Were they burning leaves and rubbish? No. Was the smoke extension heavy, light, moderate? And this is subjective. Was it normal, a nuisance, or, offensive? And you know how that goes. You got those people that are burning supposed clean, dry wood. It's the couch that they pulled out of their basement. And their neighbors are complaining, and the smoke's banking down and going right. That's a nuisance, or it's offensive. So we'll just say that in this situation it was normal. The materials that they're burning. This is all based on the Ohio EPA's regulations for burning. The Ohio EPA says clean, dry wood only. That's not leaves. That's not wet wood. That's not your couch from the basement. So in reality, they're pretty strict. But if it's clean, dry wood, and it's reasonable size, and it's not bothering the neighbors, the EPA says that that's fine. So we'll just say that they were burning clean, dry wood. And then the next tab is safety. So were they greater than 25 feet from the structure? The EPA or the Ohio Revised Code or whomever says that any open burn needs to be at least 25 feet from a structure. If it's greater than 3 by 3 by 3, it has to be at least 50 feet from a structure. So what was it? So we're going to say that it was greater than 25. What was the suppression mechanism that they're required to have available? A fire extinguisher, a water hose, or some other means. We'll say that they had a water hose. Did you extinguish the fire, or did you advise them? So not extinguished. We advised them to extinguish because it's a nuisance. The occupant extinguished. Was the fire attended to? Because it is a requirement, again, from the, help me out, I don't think it's EPA, obviously, but like the Ohio Revised Code for open burns and EPA kind of work together, and you have to be 25 feet from the structure, and you have to attend the fire, and you have to have an extinguished mechanism. So those are all just parameters, and you're going to see those here in just a second. And then wind speed is the other thing that they're concerned about. Basically the bottom line is you guys, as the agencies overseeing your communities, have the right to say it's hazardous to burn here. Either the Wildlife Foundation or the Parks Administration or the EPA says, that the environment is not safe for open burning, or that the ground conditions, it's too dry, it's not safe, or hey, where you're doing it, the wind's blowing it right into your neighbor's flammable garage. It's not safe. You have that right to stop unsafe practices. So we'll say that the wind speed was less than 15 miles an hour. These are the regulations according to at least what we have available. That the code official shall prohibit open burning that will be offensive or objectionable due to smoke or odor emissions, and when local circumstances make such fires hazardous. So basically what they're saying is, if it's offensive or you think it's a hazard, you have the duty and the right to stop them from doing that, even on their own property, within reason. The code official shall order the extinguishment by the occupant or by the fire department for any open burn which creates or adds to a hazard or objectionable situation. And the idea here is you're meeting with these people, you're trying to be reasonable, they're a paying citizen to your tax base, and you're just kind of letting them know what you're there for. These are the things that we need to make sure you understand. That the pile size is not greater than, and the EPA is saying 3 by 2, so 3 foot in diameter by 2 foot high. That's a pretty small fire if you think about it. But that's what regulations that we have say. That it's greater than 25 feet from the structure, and then that you are burning clean, dry wood only, and that it is attended, and that you're supposedly not allowed to burn openly from 6 to 6 in March, April, May, October, and November. And then you can say, yes, we reviewed these regulations with that occupant, so they were advised. And then you can sign and you can do the email, same kind of concept here. Put their email address in, have the crew sign. And when we look at the report, it's going to look very similar. It's got the incident address, the attributes of the call, the pile size, the safety factors, your remarks, your truck, your crew. And then there's just that second page is kind of that breakdown on the regs. The things that the things that they would like you to try to comply with. So anyway, again, that should help you guys too. You know, that's another form that we were carrying, that we were interacting with quite routinely, to basically let them know why it is that we're there, what empowers us to make the decision on whether or not it's safe or not, and if we require them to put it out, at least they have the ability to know that they can contact the EPA anytime they so choose. And then also that if we get continued calls to that residence because of a nuisance fire, that they're likely to get a knock on their door from the EPA, and that usually stops them from, you know, offensively burning. So the other thing you'll notice under that records tab, so you've got the CO incident, you've got the open burn. I did move our fire service and civilian casualty reports to the front side. The reason being, you may have a fire service casualty that wasn't on a structure fire. Well, I had that in the structure fired side because it's a NIFRS report. But by talking to people and thinking the logical process through, you could have somebody get hurt that wasn't a fire. I mean, they could have gone to a food on a stove, which doesn't require a fire module to be populated, and burned their finger on the pan when they took it off the stove. Well, that's a casualty, and you can interact with that from the basic side now. And if you want to see a quick example of that, fire service casualty, if you pick your crew member, it'll populate their name. I don't have my first names assigned to the default our agency's thing here, but you put in their age, their gender, whether they're career or not, and then you just go down through all these different fields and populate the appropriate values. And you can see I can fly through here. Whoops, I had an amputation. So whatever this happens to, there is no real validation criteria on this per se. And then the date and time are at the top, and that should be populated with the date and the time of the actual casualty. And then you can move down and do another one, you know. So if you happen to get two guys got burned on that open or that container fire, you can put both of them in there. So anyway, I moved that to the records. Anything that has to do with a record, duplicating a record, replicating a record, syncing a record, doing an additional record extension with an open burn, a CO, a fire service casualty, a civilian service casualty, and then hazmat, obviously, is in there as well. I know Norton had a hazmat call. You guys had asked about the hazmat module. That was last year sometime, or beginning of this year. But so that hazmat module, hazmat access is there again from the basic tab to be able to get into that. The other thing I did add at the request of an agency, and I thought made perfect sense to all of us, is in the persons involved, there's a button in the middle bottom there that says vehicle. So the NIFRS will allow you to collect vehicle information if it burned, but if it didn't burn and you want to collect some information, they didn't have it available. So I put those fields in there and allow you to collect the year, make, model, license plate, serial number, and insurance company from a vehicle on just a basic incident, you know. Maybe it's a no duty to treat call and you wanted to document that, or maybe your protocol is anytime there's a car involved in an accident, even if it doesn't burn, we want that information. There you go. So you can populate it. It will populate in a different area of the report than if the fire was in a vehicle. What I may do is put a button in the fire module so that if you happen to interact with these, you can populate that was the vehicle that burned. But they are actually two separate sets of fields because, like I say, NIFRS wants that if the fire was in the vehicle or if it was a part of the fire. But I get people that are saying, well, I'd like to be able to populate that on a minor fender bender. We've always collected that. I want to be able to collect it. So here it is. And I'll just populate it. We'll put a 2015 Acura test model, license, VIN number, bunch of numbers, insurance company. I don't have that as a drop-down. I could make it, Allstate, Geico, other. I probably will. We'll just put Geico on here for right now. And if we go to the actual report, so that you're aware, you will see that information 3/4 of the way down on the first page of the basic report there. Year, make, model, VIN, and all that stuff's there. if you have a reason to collect it, it's available to be collected now. I did change some of the workflow inside of the NIFRS fire module. I can give you a really quick explanation on some of the minor changes that were made. I'm stopping you as soon as you say that it was confined or not, and then I'm going to allow you to either populate all those values with undetermined or interact with them individually. The number of buildings involved, number of units, what the total value of the property was and what the loss was, what the value of the contents were and what the loss of the contents were. You'll notice here you can get to fire service casualty and civilian casualty here if you wanted to.
That loss value, that's optional, right? Can you force it? Can you set it up so it's forced?
I mean, I walk you into it. I don't think the NIFRS requires a number, but obviously they would like to know what
I've run into a lot of times is there's just nothing in there.
they're not popular. Well, see now, is the current solution forcing them into that field? See, I'm not positive on that. I'd have to double check the order. But like right now, when you pop into this this particular popover, it drops you into the number of buildings. And if I say 1, 1, I drop into value. So I'm kind of like, yes, I think I may have changed that workflow a little bit because I know building and stuff was in a different place. So now it's how many buildings, how many units, because I might have an apartment complex with 6 units for one building. And then what was the value of that property? And literally walking you through those. And, yeah. Yeah. The property, mobile property and equipment involved changed ever so slightly with the fact that I can jump between them. So here's equipment involved, and there's a button there that says reset equipment. So if I go in there and I just really mess things up for some reason, I can hit this reset equipment button and it'll just null them out. Or I can go in and deal with the mobile. According to NIFRS, though, you can't have mobile and equipment. It's one or the other. The structure fire portion of it, the biggest change that I made here to workflow is going to be here. So was the fire contained to the object of origin? If it was contained or confined to the object of origin, you'll notice that nothing comes out below fire flame spread. If, though, I say that it was confined to the room of origin, then it's going to say, give me the items contributing to the spread and also the materials, or the item contributing to the fire spread and now the material contributing. What was the length of the structure, the width of the structure, and how many floors above grade, how many floors below grade, and then you can see that you have below that is the number of stories that had damage of 25% or less, 50% or less, 75% or 100%. Little workflow change here. When you say that detectors were present, what type? Smoke? Were they hardwired, battery only? Were they a combination of both? Did they activate? Yes. And if they did they alert the occupants? So they alerted and the occupants responded. And then a little bit of a workflow change here. If the AES system was not present, it's done. You know, before, and it was my fault, I didn't actually think too much about it, but if you didn't have an AES system, I presented you with those fields, and then people would just go and interact with them, and then they didn't know how to get the stuff out of them. And the NIFRS validation criteria says you can't have any values in any of those boxes if there's none present. So I created that issue that I've now resolved with the workflow by saying don't even present those boxes to them if they weren't present. However, if they were present, then what type and what is the operation. Did they operate? Did they fail to operate? So we'll say that they operated effectively. And then how many heads were actually activated? And then you'll clear. So, yeah, that should help you. I mean, again, you could go back to the cut copy, to remove values, but if I'm walking into fields that shouldn't be populated under different results, then that's my error. And I did change that workflow on both detectors and AES. Because if detectors weren't present, I'm not going to ask you if they alerted the occupants. And if AES wasn't available or present, I'm not going to ask you if it went and how many heads and everything else. So I did improve that workflow. Oh, and so you... Not that I even need it any longer, but you'll notice there's 2 buttons in the middle there that will allow you to reset the detectors or reset the AES system. So again, for those people that say, I put all these values in here and it's not right, they shouldn't be there, well, hit the reset button and then it'll take them all out of there for you. So I kind of redundantly help you with that. Also, too, I believe, let's see here, and so if I say none present, because there's values in there, I'm not hiding those fields. If I reset and say no present, then I'm not even showing you those fields. But I'm still going to present them to you if you've populated a value so that you can see why it's not validating correctly to the NIFR side. So some real simple, subtle NIFR's improvements to workflow, added the CO, added the open burn, put the civilian and fire service casualties on the front so that you can interact with them, clean those reports up a little bit too. The hazardous materials type incident report is also available there. And just so you guys understand, somebody questioned this the other day. Notice that my arson tab is not available. The reason that it's not available is because in order to present you with that, the fire has to be intentional. So if you want to interact with those arson options, go to your ignition, and on the left side you'll notice that it says cause of ignition, bottom value. If I say intentional and I jump back out of here, you can see now I can interact with the arson tab. And this arson tab is, I called an agency in from the outside, maybe the state fire marshal, and they brought their dog and we walked around and we found these things, and it was a juvenile and here was their age and they had a bad upbringing, and there's all kinds of fields in there attributing to the things that they're looking for. It's not an arson investigation module. It's an arson populated report for the NIFR side of things. And talking to Hargrove, too, I really would like to put together, at some point, an arson investigative module. So you kind of come, like we're doing with the open burns and stuff, where you come off of that NIFRS incident and then you tackle all the things. I got a witness statement, I got some pictures, I've got... I interacted with these 18 people that were, either involved or witnessed or family members, and then here's some attachments for statements, and, kind of have that ability for you to just branch off of that NIFRS call and do a full-scale investigation. Called in the state fire marshal, the dog was there, we got our arson information indicated for NIFRS, and really take that full circle. And I asked Hargrove about maybe assisting with, with what it is that we need. I don't do arson investigation, but I'm pretty comfortable with the concept.
We have a whole book in each engine. We have a team from 8 different communities. And it's every piece of paper you just mentioned. So if you want copies of those, I can get them to you.
Well, I think that would make for just additional usefulness of the IMS system, because it's going to happen. We're going to have arson investigation. And why have Norton doing something different than Barberton doing something different than Plain if we have a standardized, hey, these are the basic, kind of like we do with NIFRS. This is the basic stuff you should be populating values in. I think we could put something together. And the benefit to that from our perspective is, since we're not writing all that information to the state, we don't have to stay inside of their sphere of control. So it can have all kinds of other values that you can populate on your own, and a series of reports, and allow for, like, maybe instead of having the person involved or the witness statement typed on a tablet, maybe you have just canned, witness statement that they write on, but you attach them as documents to your arson investigation. I don't know that it's appropriate for you to give them your tablet and say, document. It'd probably be easier to give them a piece of paper and then append that as part of an arson investigative report. So he liked that. Questions on NIFRS, fast, down, and dirty, easy to get through, just enhanced. Nobody should have to relearn anything other than look at that records tab and understand that I've got some more reports to interact with there. We're doing good, time-wise, relatively speaking. I'm going to jump over to plane here. John was concerned that some agencies do and some agencies don't realize that we have some other functionality that they may not be taking advantage of. And I want to point those out to you guys so at least you're aware that they're available. They do require some additional setup depending on what you guys are doing. First thing I want to show you is our resources module. And in order to get there, we always take you to our splash page, which is this. And you obviously are almost always going to the EMS and NIFRS. The bottom button is allowing for those updates to occur. If we need to have you, go out, or maybe you had a problem or you lost something or whatever, you can bring the solution back down. But the right and left, you see the resources and you see the fire prevention. I want to show you the resources really fast. So I'm going to go to our resources, and I am in his plane here. We've got a time journal, a training journal, and a not totally completed but still effective checklist module. So the first thing I want to do is show you our time journal. And this is how we log our crew members in at the beginning of our shifts. And just so you know, we require whoever the shift supervisor is to be responsible for logging the crew members in for the day. Because when you allow the crew members to do it, sometimes they do it, sometimes they don't. There's no accuracy to the record keeping. So I'm going to go to the time journal. And if today was a shift duty day that I wanted to record the personnel for, I'm going to say I got a new shift tour. This is shift 3. I am making the report. And if you'll notice, right beside the member making for career departments, that yellow crew button will allow me to bring everybody that is assigned to my day in. So everybody that's assigned to third shift is now populated. But we almost always have 2 guys off a day. So this guy happened to be on vacation today, and this guy happened to be on Kelly Day, which is what we call EDO, or earned day off. So he's EDO, but everybody else showed up today. And you can see the left and the right of the names. I've got a starting tour and an ending tour. So you'll notice there's a time and a date. My guys started at 0700, and unless they go home, they're going to finish their tour 07 tomorrow. So that's already done. Technically speaking, if nobody says they're going home or anything else, I'm done with my shift tour, because we're career. We got 12 guys assigned to a shift. 2 guys are almost always off. 1 guy's vacation almost always. 1 guy's Kelly, and everybody else is there. Now, if, for instance, you had, maybe another guy that was traded in, so for instance, I'll allow for me to see my second shift crew members. This guy was traded in, and this guy was traded out. So it'll allow you to track those crew members coming in and on and off tour. Real simple. The training module, this one you should like. Norton, you guys are using this, aren't you?
Yes.
Barberton? And Wadsworth is here? Somebody from Wadsworth is here? You're from Wadsworth? Okay. Are you guys using okay. So let's do a quick training event. And I do want you to understand that the training, because things are specific to agencies, are allowed to be changed for agencies. And I'll give you an example of that. So we're going to do a training today, and it's going to be 2 hours on Venator and search. Okay, so I'm going to start a new event. Again, what shift? It's today's shift. Who's making this report? I'm making the report. Who's the instructor? Craft. Where is it? And this is customizable, this location. So we're going to do it at our compound. What was the category? It was fire. What was the primary objective? Fire suppression. What type of drill? Because you can have an individual drill, you can have a company drill, and that's customizable. All 4 of these fields. What type of training, where the training was at, what type of drill, those are all customizable by the agency. So I'm going to say we call it a company drill. And at what time did you start? We started at 11 o'clock, and we went through till 2 o'clock. Did it qualify for continuing education? If it's a fire type training and your fire chief sanctions it, it counts to CE. Doesn't matter what it is. Fire chief has to sanction it. There's supposed to be at least 3 reasonable objectives, but if it's a fire type training and your fire chief says, yeah, then it qualifies. If it's a medical type training and your medical control board says that it's appropriate for CE and they issue certificates, then it is. If you guys just got together and talked about your standard operating guidelines and there was no CE, then it doesn't qualify. So we'll say, yeah, it was. So up here at the top, we'll say fire, yes for CE, and it was 3 hours worth of CE. The other thing, too, you can do here is, hey, we did this great training, and we thought it was so good we invited Norton. So you could go in and you could pick Norton from your mutual aid companies that they came along with you. I don't think Norton's in my list here. In fact, I don't even know who Ruggles Troy Fire Department is down here. That we just threw them in arbitrarily. We'll just say Jackson came, and maybe North can, you know. Maybe we had a couple agencies that maybe we did a night training or, you know, water operations, water shuttles, whatever. And then also additional instructors. Because a lot of these guys that have instructor cards have a certain amount of continuing education requirements that they have to do so many hours of instruction. So if I happen to be a fire instructor and Kraft's the primary instructor, I can be the supplemental instructor under his guidance or whatever. So we'll say that I was also an instructor here. The other thing that I like about this module, and let me finish this real quick, I guess, and then I'll show you. So we've got all of these basic parameters met. Now, who was there? Well, I'm going to put everybody on my shift except for this guy, because he was, well, these 2 guys were off today. So everybody's brought in, or I can pick them individually. And then this is just a generality comment, you know, whatever you want to say. We trained. You know, you can go on and on and on. And then, just like fire prevention, here's your objectives. So go in here, and if any of you aren't aware, you can talk to these devices. And if you speak clearly and concisely and break your sentences, they do a pretty good job. Vent, enter, and search. See, she thought I said something a little bit different there, but let's do water supply. Not bad. Incident command. She does okay. You can list out as many objectives as you want. Also, if you notice too, to the right of the objective, it says yes. I'm just saying you met the objective. But if you happen to have 6 objectives and you didn't have time to finish, or your crew just couldn't get it together today to finish all of them, you could say that you did all but this one. You know, we didn't meet the requirements of that objective or what have you. We can attach attachments to here. So if you wanted to happen to, maybe you had some kind of a high-angle rescue and you had a Z-rig out and nobody knew how to put it together, so you wanted to capture a picture of it so next year you knew what it looked like, you can do that just like you can anywhere else in here. We can take a quick picture, you know. Now I'll just take a picture of the counter here. Also, if you happen to have that same high-level or high-angle training and you had a 5 or 10 or 20-page PDF of, you know, here's all the different riggings, you know, hauling systems, lowering systems, belays, you could attach that PDF right to here, and then next year when you go to do the same training and nobody can find that syllabus, you'll have it as a document of that training. And then to make that even better, next year, you'll notice right in the center there's a replicate button, and that will replicate your objectives and your location and all that good stuff, and then you just populate different crew members. And we use that. We train, we're career, and we run a first, second, and third shift. So we start on Wednesday doing a company drill. That same company drill will be done on Thursday and then once again on Friday. So whoever's the station supervisor or the shift supervisor puts Wednesdays together and makes sure they do the objectives and everything correctly, and then Thursday just replicates, puts their crew in, Friday replicates and puts their crew in. So it gives you a nice report at the end that basically lists out your objectives, the crew members, the time, the location, and all that good stuff. And then you can go back and search. Show me all of Steve Ione's trainings that he did in 2016, and it'll list them all out. So if you happen to get audited from your fire card by the state, or if the ISO comes in and they're asking you how often you mutual aid train, or they're asking you how often you do company drills or whatever, you'll be able to run statistics on that kind of stuff. So quick, easy, down and dirty, easy way to get training logged, and then mutual aid, additional instructors, all that kind of stuff.
How do you run that report?
You do it on the dashboard, like on your computer here. You would actually do it from your console that you guys operate on as a gatekeeper, but you can look at, for instance, just a specific crew member or just a specific type of training, and for date ranges on your dashboard. Have you ever looked inside of the resources on the dashboard?
Yes.
And you're with Norton? So you can call me if you're looking. You guys are using those.
Yeah, we started using it April 1st.
Yeah, so I do want you to understand how you can bring back that information to make it available for ISO or crew members. If a guy's got a card coming up and you were accurately documenting, like Ashland Fire Department, if I was working for Ashland and I did an online CE last night, I'm required to actually put that in as a training event. And then they can actually bring back and show where I would be in relation to my expiration date on my card and how many hours I have or I am short.
So would that be a custom report?
The custom, just because you're asking, is where you would go in and assign like your categories. Here's all the categories that you guys saw. What type? Administrative, fire type training and stuff. And then drill types. These are what I call them. I can eliminate or change any one of those. And locations, you saw we have an on station, off station at the compound at Central Station. Yours might be, the college next door, the old schoolhouse, whatever you happen to call your training sites. And you might even have, Bowling Green or Stark State or, a college or whatever the case might be. The primary objectives. So those primary objectives based on so if I said I was doing fire training, I'm going to see fire suppression, search and rescue, water supply. If I chose EMS, I'm going to get ACLS, trauma. These are all my categories. Now, what I recommend is that when we, if we dial you guys in, we push you our generalized categories, and then you got a place to start from. Most of the time, you're going to see the things in there that you're going to want anyway, cardiac, respiratory. But if you want to add some or you want to modify them a little bit, you've got a good starting point.
You know the car seat inspections?
You can do that too. In fact, Ashland does that. When they do a car seat inspection, they create a training log. Don't ask me why. Maybe so that they can say, we did 100 of them this year, and they're actually logged as training events. And you could put that in there. You could say that my primary category is public safety, and my subcategory is car seat inspection, and then just do a training. It was just me, and I don't have a place for you to say to document the owner of the vehicle, but you could put that in your narration or whatever. Real easy, right? Where I'm from, and if any of you don't know, I work with Plain Fire. We do all of our training on our desktop. In fact, we do our time journal on our desktop. Just because that's where we do our shift change, shift supervisor to shift supervisor. We're in an office that has our schedule, and while we're sitting there exchanging the shift, we go in and put our crew member in, and then if we happen to have done a training yesterday, we just replicate that guy's training from Wednesday to Thursday. So we actually do that on the desktop. You can do it from the device just as easy, and then there is a sync button up at the top to send that record up to the server. Really comes down to how you like to operate, I guess. Did any of you check your drugs for expiration dates? So I put in a quick, easy way for you to go about that. I have two different iterations. One is a drug check, meaning I take my set of gear and I look through it and I compare it and make sure that I have all the drugs I'm supposed to have and the quantities I'm supposed to have on board. We do that every Monday with our set of gear. Every third Monday, we check our gear for, every 6 weeks, we check our drugs for expiration. So I'll show you an expiration check real quick. So I'll go to the checklist, and I'll say that I'm going to do a new expiration. Today's shift, it was me, and we'll make this guy. I was at Station 1 on Medic 1, my primary set, and I'm going to go to the middle drawer. And if I go to the top, I'm going to have all of the drugs that I said that were on my truck in the middle drawer. So I'm going to pick Dacryos. And if you notice beside Dacryos, it says I'm supposed to have 1 bottle. Now, that's for you guys to determine what you're supposed to have as far as volume of the drug in that particular location. So if I'm working with another partner, which is what you're supposed to do when you're checking expirations, and I ask you what your expiration is on Dacryos, and you say January of 17, I just populate that. So you see the first 6 months of the year on the left side, the other 6 months are on the right side, and above the months you'll see an increase and decrease of the year. So if I inadvertently said 17 and you said, well, no, I'll make that 16, if I click down, you'll notice that the year changes. So here I am pushing the button, you can see the year changing. And if you say I have 2 of those, I can just hit the replicate button and I've got 2 of them. If I say next drug, you'll notice that Dacryos is removed from my list, and I'll move to dextrose. And let's say you say June of 16. Well, you'll notice that the drug date is red because it's within 30 days of expiration. That should indicate that I probably want to pull it and replace it. And if I am going to replace it, I'm going to put in the drop down for exchanged as yes. And you indicate to me that you have 5 of them, so I just replicate, replicate, replicate. You'll notice there's a sequence number on the left, so if you say I have 5, I just want to get to iteration number 5. If I go too far, there's a trash can that I can take that last iteration out. And then I'll select next drug again. Dextrose is gone. So you kind of get the point that as we work together, you and I will both run out of drugs simultaneously. I will have no more drugs to choose from. You will have no more in whatever location. So it's not specific to the apparatus. It's specific to the station, apparatus, location, and sublocation. So Station 1, Medic 1, Set 1, blue bag. Station 1, Medic 1, Set 1, top drawer. And that's all customizable by you guys. And you can indicate, that I've got epi in the blue bag, the red bag, the green bag, the top shelf, bottom shelf, middle drawer. You can put it wherever you want it. And then you guys basically set up your first truck with the proper amounts, and then I've got the ability for you to say, Medic 1, replicate to Medic 2, replicate to Medic 3, if you keep a standard location with your drugs, which most people do, because then it makes it easy for your medics to find what it is they're looking for quickly. So very, 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 very simple. And then if you happen to indicate that you exchange the drugs, when you get done with this entire report and you look at the review page, I've listed out all the different drugs, and at the very top I can say, just show me the ones I indicated need exchanged, and then that'll tell you what drugs you pulled from where and where you need to put them back when you bring them back from the pharmacy. Okay.